Hello students, welcome to this tutorial of pharmacokinetics. So basically we already passed through the MCQ, the notes on So what we are supposed to do today is just to pass through the MCQs and give a little bit of an explanation. So now we talked about the absorption, distribution, metabolism, and elimination of drugs. This was basically ADME as an abbreviation, which specifically addresses the pharmacokinetics. Yeah. So, and we discussed these processes like the absorption, the distribution, the metabolism, as well as the elimination of a drug. So we went ahead and talked about the absorption of a drug, and we looked at the absorption of a drug, explained a lot of things, method by which a drug can be absorbed. We also looked at factors that affect the absorption of a drug through the GIT. Then we went to distribution. We also talked about factors that affect distribution, just like that. Protein binding is the one on the left, and then on the right it is about the capillary permeability. And we said the capillaries that are located specifically in the liver and the lungs allows drugs to be distributed even to those organs or other tissues, as compared to the kind of capillary that is located in the brain. It restricts some drugs to reach there, except those drugs that are lipophilic, meaning those drugs only which are hydrophobic. They're the only drug that can cross the capillary membrane of the brain because it's a continuous one. Then we went on to talk about the metabolism of a drug. We just described to say that this is the biotransformation of a drug. Specifically, the major reason why we do the metabolism of a drug occurs, we describe it to say it is to render the drug more water soluble, so that it can be it can be easy to be excreted. Yeah. So we looked at them, phase 1 and phase 2 of metabolism. It's very, very much important for you to know the phase 1 as well as phase 2 of metabolism, because questions are going to arise from that angle. What is phase 1 and what is phase 2, and mention some processes that occurs in phase 1, mention some processes that occurs in phase 2. So it's very, very much important you take that into consideration. Then we talked about the cytochrome P450 being an inducer and an inhibitor. On the inducer side, we said these are drugs that actually accelerate the metabolism of the liver. Then what happens? If the drug stays within a short period of time in the body, then it is eliminated, then it is not going to do its intended function. And then how about an inhibitor? An inhibitor, we said, if a drug is if the metabolism of a drug is going to be delayed, meaning it's going to stay for a longer period of time and it is going to have undesired effects. Okay, on the inducer I gave an example of the effect of rifampicin on oral contraceptives. So rifampicin is an inducer and it causes the liver to metabolize the oral contraceptives, for example like levonorgestrel, to metabolize it so fast that before it even does its function to prevent pregnancy, then it comes and obstruct that function basically. So someone can still fall pregnant for as long as they are on TB treatment and they are on rifampicin, then they take oral contraceptive. That's how I explained it. And then on the inhibitor, I said we have grapefruit juice that acts as an inhibitor. And in case of nifedipine, which is the drug that is used in the management of high blood pressure. So of course the blood pressure is high, we want to lower it, but we don't want to lower it below the normal or average. So now grapefruit juice being an inhibitor, what it does is that it is going to cause the BP to go below the average, as in we can talk about optimum where the body operates best. Why? Because it's going to prolong the function of nifedipine by what? By slowing down the metabolism of nifedipine. What does that have to do with hypotension? Because nifedipine lowers the blood pressure to a level where it's normal, but if it stays too long in the body, it's going to lower it below average. That's basically what we said about cytochrome P450 mnemonic, about an inducer and an inhibitor. Then also looked at the elimination of a drug using zero order and first order kinetics. We said in zero order kinetics, the elimination remains constant, meaning if at all a particular drug, for example alcohol or high doses of aspirin, please take note, high doses of aspirin, if at all that particular unit, for example, I'm going to just say units, if at all 10 units are being excreted per minute, that's basically it. No matter how much you increase the concentration, that remains the same. So basically there's nothing you can do, meaning the elimination constant remains the same as compared to first order kinetics, where the elimination of a drug depends on what is available. So it depends on the concentration, okay, and the half-life of that particular drug. That's what we said about zero order kinetics and first order kinetics. Then we looked at the method of drug elimination. These are various methods of drug elimination. After a drug has been metabolized, then it can be eliminated through renal excretions, through urine, biliary excretions, as well as pulmonary excretion. Okay, so basically from here, we're supposed to start answering quiz sessions because the test is soon. So I'm just going to explain, because I've received quite a number of questions in my inbox concerning pharmacokinetic questions. So I just decided to also answer these questions individually. So now, the first question says, pharmacokinetics is, so this question, first of all, I advise my student to make sure that you understand the question. Pay attention to the question, because the question is the scenario. If you don't understand the scenario, then you know nothing. So pharmacokinetics, we want anything concerning pharmacokinetics. This is what it means. So A, pharmacokinetics is the study of biological and therapeutic effects of a drug. This is wrong. The biological and therapeutic effect of a drug talks about the pharmacodynamics. Then B, the study of absorption, distribution, metabolism, and excretion of drugs. This is basically what we've been talking about pharmacokinetics. Then C, the study of mechanism of drug action. C is wrong, because this is pharmacodynamics. And then D, the study of method of new drug development. Basically not related to pharmacokinetics or pharmacodynamics. Then I say the answer is B, because it's the study of absorption, distribution, metabolism, and excretion of what? Of some drugs. So that's pharmacokinetics, and it's abbreviated by, for those who want to learn more about pharmacokinetics, it is abbreviated as ADME. ADME. So this ADME is the absorption, the distribution of a drug, the metabolism of a drug, and finally the elimination of a drug. And this is what we're basically looking at in the first notes when we're describing this. Absorption, this is just the process that involves the movement of a drug from the site of administration by whatever route. It could be oral routes, it could be intravenous, for as long as it finds itself in the water, in the bloodstream, which is the general circulation. Distribution, the drug now can irreversibly leave the bloodstream and go into the interstitial space, where it's going to find the tissues, cells, so that it can act on. Metabolism, we just want to transform this medication. Sometimes some meds are toxic, some meds are inactive, and some meds are lipid soluble, so we want to transform them, hence biotransformation. Okay, and then there's elimination. Find out how the drug has worked and it need to be eliminated out of the body, because if it remains in the body, it becomes a metabolite, which is a toxic substance. So I hope we are together on that particular. Then let's go to question 2. So question 2 reads, the main mechanism of most drug absorption in the GIT tract is. So basically here we are looking at, yes, there are a number of mechanisms in which a drug can be absorbed through the GIT, but the question is, what is the main mechanism? Or rather we can say, what is the most method that most drugs used in order for them to be absorbed? That's the question that is saying. A, active transport. The color-mediated diffusion, this active transport is not the main mechanism drugs used in the body. Filtration, only small amount, just like active transport, only small amount of medication can use filtration. For example, the transcellular movement of drugs using the adjacent, just like that, yeah. Then apart from that, we have endocytosis and the exocytosis. Basically, no. Okay. So remember when I was teaching you to say the main mechanism of most drug absorption in the body. So I remember explaining to you the major mechanism that most is used by drugs, okay, for them to be absorbed in the GIT tract. And I said passive diffusion. Why passive diffusion? This is because most of the drugs have smaller molecules and they are lipid soluble, so they are able to move across the cell membrane because we have a hydrophobic core. That hydrophobic core can only deal with things that are water hating, and those are lipids. So this is the reason why passive diffusion becomes the main mechanism of most drug absorption in the GIT specifically. Are we together? So never forget, it's passive diffusion. So now I'm just from explaining this question, you're able to answer it. The question reads, what kind of substance can't permeate membranes by passive diffusion? So the first thing you should ask yourself is, what is passive diffusion? Passive diffusion, we mean to say only drugs of lipid nature can pass through using passive diffusion. You get that? So that's where the concept is. Only something that has a lipid nature and has small molecules, that's when it can only easily pass using passive diffusion. So A is saying we are looking at something that cannot permeate membranes by passive diffusion. A, lipid soluble? No, because this is a lipid substance. So it's going to pass through passive diffusion. It's going to move using the pores in the membrane direct. Then B, non-ionized substance. Okay, so basically the non-ionized substances, these we're talking about those that are not charged. Uncharged, we're talking about uncharged molecules. Uncharged molecules is, yes, but it doesn't necessarily to say that they need to use ionized substances, like they need to necessarily pass through using passive diffusion. Let's try to look for another option that is going to be sound much better than this. Then C, hydrophobic substances. On hydrophobic substances, these we are basically talking about lipid as well, okay, that are something that is water hating, can easily pass using passive diffusion. But let's look at hydrophilic substance. A hydrophilic substance, we are talking about water loving substance, because hydro means water, philic means affinity, so meaning there is love, so we call them water loving. Any water loving substance cannot easily permeate membranes by passive diffusion. Always know that point. It is never, because hydrophilic means it is water loving and it cannot pass using these means. So take note of that. It's hydrophilic substances specifically. Okay, the reason why non-ionized substances qualify to be an answer, because all those molecules that are not charged, they don't have issues moving across the cell membrane. Okay, those that don't have issues. So this one qualifies to be an answer in this instance. But if we are looking at the best answer, probably we need to talk about in terms of hydrophobicity and hydrophilic. So the correct answer here is D. Hydrophilic substances cannot permeate membranes by passive diffusion. Let's go to question 4. So question 4 reads, a hydrophilic medicinal agent has the following property. Something that is water-loving kind of medicine has the following property. So we're just looking at the something that is water-loving. What are some of the properties that it has? Something that is water-loving, what are some of the properties that it possesses? So question number 1, low ability to penetrate through the cell membrane lipids. Yes, it has the low ability to penetrate through the cell membrane lipids because it is hydrophilic. So let's see to question B. We are going to put a question mark there. Then B, penetrate through membranes by means of endocytosis. Not necessarily describing the process that it uses. They can use various processes. That's why this answer might not be correct, because it is talking about one specific type of transport, and that's being biased. C, easy permeation through the blood-brain barrier. So the blood-brain barrier, I know I told you about the capillaries that are found in the brain. This one is a continuous capillary, and the continuous capillary, for that reason, is going to require a hydrophobic substance to pass through, not a hydrophilic. Only substance that is of lipid nature can cross the blood-brain barrier. You understand? So if they say is penetration through the blood-brain barrier, this option is wrong, because we are talking about hydrophilic medicinal agent. Only a hydrophobic medicinal agent can easily permeate through the blood-brain barrier. Then D, high absorption in the renal tubules. Has nothing to do with absorption. Absorption in the renal tubules depends with the pumps that are there and the need of a substance in the body. If the body doesn't require that substance, gets to be excreted, so the absorption does not necessarily have to do with the kind of or nature of hydrophobicity or lipophilic. So what's the answer here? The answer here, A, remains to be the best answer, because any hydrophilic medicinal agent have low ability to penetrate through the cell membrane lipids, and that remains stand out to be the correct answer. So now let's go to question number 5. Question number 5 says, what is implied by active transport? By active transport, what does it mean when you say active transport? We said active transport is further divided into what we call the primary active transport and secondary active transport. And the hallmark feature of active transport is that this kind of transport requires ATP to transport substances against the concentration gradient. Okay, so that's basically about active transport. So now let's check through the answers. A, transport of drugs through a membrane by means of diffusion. Now, this is wrong. B, transport without energy consumption. This is totally wrong. C, engulf of a drug by a cell membrane with a new vesicle formation. This is basically this is active transport, but specifically transport under the membrane. So it could be the correct answer, or it can be the wrong answer, depending on the next option. If we can find something better, then this is going to be the wrong answer, but it's partially correct. So if you find a better answer, we're going with that answer. If you find the answer that is worse than this, then we're probably going to go with the C. So D says transport against concentration gradient. So basically here we are looking at the general answer for active transport and not specifically talking about endocytosis. We are not talking about the endocytosis or exocytosis. Yes, they are transport under the primary active transport, but it's not necessarily us talking about it only or generalizing the active transport using endocytosis or exocytosis. So what is something that is generally talking about active transport? It transports substance against the concentration gradient. So that's the answer. Let's go to question number 6. Question 6 reads, what does the term bioavailability mean? So now, before this, let me just bring out the concept for bioavailability. So what do we mean by the term bioavailability? By bioavailability, we are basically trying to compare looking at the routes of administration of a drug. Yeah. Then we want to look at what is present. We want to look at what is present in the bloodstream. Okay. So in other words, please bear with my handwriting. I'm saying route of drug administration compared to what is present in the bloodstream. So in other words, we're saying if you administered 500 milligrams of paracetamol to this patient, we are saying how much of the 500, how much of this drug is going to be unchanged, meaning how much of this drug is going to reach the bloodstream. If out of this drug about 500 reaches the bloodstream, 500 milligrams reaches the bloodstream, so we can calculate it by using the formula. Not really any formula, but we can say we are going to divide by what you administered. What you administered, you are going to put it below. Then, the drug content. What the entire drug you gave, you are going to put it below. Then, how much has reached the bloodstream, you are going to put it on top. So, the tablet had 500 milligrams, and then 500 milligrams also reached the bloodstream. Then, because it's a percentage, you are also going to multiply it by 100. Okay, so if you cancel this, you are going to remain with 1. So when you say 1 by 100, then this is going to be 100. So I want to comment on this same 100. So we are going to say this drug that we administered has 100% bioavailability. Okay, 100% bioavailability. What does that mean? What it means is that the drug that you administered, what you administered is what is in the bloodstream. So here now I need to bring it to your attention. So most drugs that are given via oral routes, for example paracetamol, these medications are given using oral routes. So they cannot have 100% bioavailability. Why? It's BA, bioavailability. They cannot have 100% BAY because they are exposed to gastric acid, they are exposed to first pass metabolism, like metabolism by the liver, so they cannot have 100% metabolism. What I mean is, if you are to administer 500 milligrams, what is going to reach the bloodstream? Maybe it's just going to reach 350 milligrams. This is what I mean by they cannot be 100% bioavailability, because maybe only 350 is going to reach the bloodstream, and you can't say this drug has 100% bioavailability. So if you can calculate, if you have a calculator, we can calculate in this instance. So we are going to say how much did you, the total, okay? So by BA, this is just my formula, by the way. We are going to say total, I'm just going to put given multiplied by 100%. So now we are going to do this. We are going to do a simple calculation. So we're going to say BA is equal to total. What was given in blue was okay, sorry, not given, reached the bloodstream. Okay, we're going to say bloodstream. This is just an example to make you understand. Yeah, so what has reached the bloodstream? We said it's 350. The total that you gave is 500 milligrams, okay, times 100%. So we are going to cancel milligrams and milligrams, then 0 and 0. So when we divide this, probably we are going to get about 67%, because we are remaining with the percentage. Milligrams have gone. So we mean to say most drugs that are given via oral routes cannot have 100% bioavailability. But you yourself have a better answer to say, then if this drug cannot have 100% bioavailability, what kind of medication can give you 100% bioavailability? What kind of route of drug administration can give you 100% bioavailability? So IV medication, intravenous, you are giving directly into the bloodstream and they are going to reach there. So all IV medication has about 100% bioavailability. You understand? So bioavailability, this is what we mean. What you have given, out of what you have given, how much of it has reached the systemic circulation? You understand? How much of it has reached the systemic circulation? That's what we mean. So I hope you understand what bioavailability means. So now let's answer the question. The question says, what does the term bioavailability mean? A, plasma protein binding degree of a substance. This has nothing to do with bioavailability. B, permeability through the blood barrier. Has nothing to do with bioavailability. C, fraction of unchanged drug reaching the systemic circulation following any route of administration. So this is what bioavailability is, but we still have options. So if we find a better option than this one, we are going to come to C. If we find a better option than C, then we are going to go with that option. If we don't find any option, then we are going to remain with C. Then let's say look at D. D, the amount of a substance in urine relative to the initial dose. This has basically nothing to do with urine. So we haven't found any answer better than C. That means C is the best answer. So whenever you ask answering MCQs, most of you lose marks because you want to go for one correct answer that you have laid. When you're answering MCQs, the elimination method works better. So why does the elimination method in MCQ works better? In elimination method, you are going to have A, you are going to have B, you are going to have C, and you are eventually going to have D. In some cases even E, but we can end there. So what happens is, if you read the question, then you just go straight to the answer that you know, you are more likely to lose marks. Because sometimes examiners can assess and look for the best answer. Then you have given the correct answer. Sometimes you can have 3 correct answers, but there's one best answer. So you need to assess each and every option. If A is wrong, you just say wrong, completely wrong. If you are doubting B, just put a dot and say, I'm going to come back if at all there is a better answer than, if at all there is no better answer than this one. Then if C makes more sense than B, you cancel it and you cancel B. Because C is better version of B. So you need to cancel C and B. Then if you find that the last option is making complete sense, then now you can go with D. Okay? Or in a case where you go and then you find that all the answers are not making sense, then you just need to come back to B because it made some a little bit of sense. This way you are never going to lose a lot of marks whenever MCQs are concerned. So basically here the answer is C. We are looking at the fraction of unchanged, not uncharged, but unchanged drug reaching the systemic saturation following any route of drug administration, and I believe this is what I mentioned. Okay, so let's go to question 7. Question 7 is, the reason determining bioavailability are, the reasons determining bioavailabilities are, so basically the question here is saying we are looking at the determinants of bioavailability through reasoning. So we want to look at what determines the bioavailability. A, rheological parameters of blood, not necessarily, but we can't say we just need to forget about it. Then we're going to be amount of substance obtained orally and quantity of intakes. Basically, the amount of substance obtained orally and the quantity of intakes has nothing to do with it, because bioavailability we are looking at how much you have given and what is the output. It has nothing to do with how, it has nothing to do with you didn't give much, you didn't give a lot, you understand. Extent of absorption and the hepatic first pass effects. So basically the absorption of a drug and the first pass metabolism, these are determinants of bioavailability. So far you found the best answer to be C. So far I've used the word so far, so C stand out to be the best answer at this instant. Am I going with C? No, because I'm not done reading through the options, so I need to go with D. What's up with D? D is saying glomerular filtration rate. Glomerular filtration rate has nothing to do with the bioavailability of a drug, because the kidney is just also another tissue where blood should reach, and it has nothing to do with affecting the general circulation of or the general effect of blood in the body. So there's basically nothing that we can conclude here except saying that C is the best answer. So if a drug has been affected, in terms of absorption of a drug has been affected, let me give an example. In case of diarrhea, if someone has diarrhea and they have taken oral medication, that means if gastric emptying is just the movement of stuffs from the gastric, which is the stomach, into the small intestine, specifically the duodenum. That's what we call gastric emptying. So if someone has diarrhea, everything becomes fast. The gastric emptying is fast. The motility in the stomach, in the GIT is fast. So what does this mean? It means there is going to be less contact. There is going to be less contact of blood and the intestinal mucosa. There's going to be less contact in between the blood, the drug, and the absorption site. So if at all there is less contact between the drug and the absorption area, then much of the drug is not going to be absorbed, and most of it is going to put to waste. Okay, and in example first pass effect, for as long as the drug has undergone metabolism by the liver, some of the quantity is going to be reduced. Okay, it's going to be reduced. So these are two major determinants of bioavailability that we can look at. Okay, so now let's go to question 8. Question 8 is saying, what is the reason of complicated penetration of drugs through the brain-blood barrier? The brain-blood barrier, this one I told you to say that the brain-blood barrier is made up of continuous capillaries, and any drug that is water-loving, hydrophilic drugs cannot move easily. They need to use a transporter. But the hydrophobic substances, which are lipid-soluble substances, can easily diffuse using passive diffusion. We are together. So what is the reason of complicated penetration of some drugs through the brain-blood barrier? A, high lipid solubility of a drug. No, actually this one is it's actually the best version of how a drug can move the blood-brain barrier. Meningitis is a disease, and it's defined as the inflammation of the meninges. And inflammation of the meninges, of course, it can have little or nothing to do with the absorption or penetration of some drugs through the blood-brain barrier. Because even in the diseased, like if someone is having meningitis, there are still medication that you are going to give, and they are going to treat this same meningitis. So you can't really say that meningitis is going to become a problem. So far we haven't found any reason that is close. C, absence of pores in the brain capillary endothelium. The absence of pores in the brain capillary endothelium, we mean this. Okay. Like others, they are made up of discontinuous capillary. When we're talking about the liver and the lungs. Okay. The liver and the lungs are made up of discontinuous capillaries. However, when we're talking about the brain has what we call continuous capillary. So this continuous capillary looks something like this. So there are no pores where substance can easily move. So for a substance to move, it need to be what we call it need to be lipophilic. Okay, so this lipophilic substance is more likely to move in fluid. If it is a hydrophilic substance, it cannot pass. Like water is going to be blocked because it is a hydrophilic substance. But any hydrophobic substance, we are referring to a lipophilic. Yeah. So any hydrophobic substance, we are talking about the same. Lipophilic and hydrophobic is one and the same concept. So this is the reason why capillary permeability is another factor that affects distribution of drug specifically. Okay. So now let's move to the next question. And that question is question 9. We have some few more questions to go. The volume of distribution relates. So what is volume of distribution? Let me give you this simple concept here. So we have distribution. Yeah. So we have distribution. So basically when we are saying volume of distribution, remember what I said? We said distribution of medication is that it need to move from the bloodstream toward the interstitium. Okay, interstitium. This is the interstitial space where it's going to have its effect on on the cells of the body. So now when we say volume of distribution, what do we mean? We are talking about what amount of a drug remains in the plasma, because the bloodstream is the plasma, as compared to that is in the interstitial space. The reason for distribution of a drug is that so that it can have its action on that particular destination. So if we have low volume of distribution, we mean to say what the amount of drug that has remained in the bloodstream is higher as compared to the amount of drug that is present in the tissues, because that's where it usually have its action. So volume of distribution is just amount of a drug that that is present or that reaches the interstitium from the bloodstream. So this is basically about volume of distribution. So we are saying what affects volume of distribution. If I got the question right, if that's not the case, then let's look at what specifically the question is looking at. But you understand what volume of distribution is. The substance is in the bloodstream. You understand? The drug is in the bloodstream, but it need to leave and go into the interstitial space. So if a lot of drugs remains in the bloodstream, then we are going to have low volume of distribution, because only small amount of drug is going to leave the bloodstream and go into the what? Into the interstitium. You get it there? Yes. So let's review the question now. The question reads, the volume of distribution relates a single to a daily dose of the administered drug. Not really making sense. Let's go to the next question. Though we have not said it's a wrong. Remember using the elimination. So we are going to put a dot here, because we have not concluded to say it's a wrong option, but we are doubting the option. So we're going to put a dot there. Then B, an administered dose to the body weight. Has nothing really to do with the volume of distribution, but let's get to see it. Unchanged drug reaching the systemic circulation. This one is BA, bioavailability. The amount of a drug in the body to the concentration of a drug in the plasma. As simple as that. You understand? So we are looking at the amount of blood in the, if this is the entire body where it should, okay, and the plasma is the intended function of medication is not for a drug to be in the plasma. You understand? So we are saying out of the total drug that has gone in the body, how much is in the plasma? The reason why we are looking at how much is in the plasma, it's not a good thing. A drug should not be in the plasma. It should go to the tissues where it's a mechanism of action. So if we have a lot of drugs in the plasma due to plasma protein binding, remember I told you about protein binding. If this drug has an ability to bind to a lot of plasma proteins, then it's going to stay, 70% is going to be in the plasma, then 30% is going to be in the tissue. You see the effect of volume of distribution? I know you get it. So now let's finish reading, saying the amount of drug in the body to the concentration of a drug in the plasma. That is what we are looking for. This is what it relates to the volume of distribution. So now let's go to question 10. I know here the answer is D. Question 10 says, for the calculation of the volume of distribution, one must take into account. So for the calculation of volume of distribution, one must take account into. So the question is saying, when you are calculating the volume of distribution, which one is the parameter that you should look into? So the first option is saying concentration of the substance in the plasma. Of course, the concentration of the substance in the plasma plays a critical role. It's important. Then the concentration of substance in the urine has nothing to do with volume of distribution, because we've never said volume of distribution is the movement of drug from urine to the glomerular filtration rate. Nothing like that. Therapeutic width of a drug action, it is affected by volume of distribution, so we can't really say we can take it into account, because if we have low volume of distribution, even the therapeutic width of drug action is going to be low. Then a daily dose of a drug has nothing to do with volume of distribution. So you get, our elimination method of answering MCQs is never going to send you anywhere wrong. You are always going to be that one person who is just unique, who stands out whenever MCQs are concerned. So the best answer here remains to be A. the concentration of a substance in the plasma. What is it doing in the plasma? So its concentration matters. You understand? It's more like you send people to say, go and work. Go and work. You need to go work in the field. But why are you still playing around? Why are you still in the load? So the plasma is more like a load, the pathway where something is going to pass so that it reaches its destination. So that's same with the drugs. The blood stream is just a pathway. The concentration of a drug in the plasma has everything to do with the volume of distribution. The first question we are going to ask these drugs is, what are you doing in the bloodstream? This is just a transport. What are you doing? You understand, yeah? Yes. So now let's go to question 11. Question 11 says, the biotransformation of drugs is to render them. So now let me explain much here on the biotransformation. The biotransformation. Transformation means to change. So the biotransformation of medication is to render them. What is it for? So I said there are some medication that are inactive medication. There are some medication that are toxic, and there are some medication that are water not water soluble. They are what we call lipid soluble. Okay, so when we say biotransformation, we are rendering the inactive to be active medication by using either one, or we can use both of them. We can use phase 1 conjugation, or we can use phase 2 conjugation. We can use phase 1, or we can use both of them, but we want to make sure that we add the medication. Okay, then in toxic, we are making them non-toxic. Then how about lipid soluble? We are converting them to water soluble. Why should a drug be converted into water soluble? Because the process of metabolism prepares the medication for elimination. So this is important that we learn this medication to be water soluble so that it can be easily excreted out of the body. However, making the drug water soluble is the main reason of bio or metabolism, to make the drug less lipid soluble. Less lipid meaning it's becoming more water. That's what it means. So whatever the science behind, just understand that it need to be in a water soluble, so that we can the elimination of these particular drugs become super easy. I believe we're moving together. So now let's go back to the question. So the question says, the biotransformation of a drug is to render them A, less ionized, not necessarily. B, more pharmacologically active. Yeah. Yes. C, more lipid soluble, not necessarily, because most of drugs, like, we want to change this from more lipid soluble to a less lipid soluble. So you see, the answer is less lipid soluble. So why is this the best answer here? Of course, B can be an answer to some extent, but the problem is that it is saying more pharmacologically urgent. This is wrong. Okay, we want to make it active. You cannot make a drug to be more active than it was by, this is what this statement means, more pharmacologically active, meaning it was active initially, but we want to make it more active. That's not the reason. It was inactive and we want to activate it. That is what we do. So B is wrong, because we don't make a drug more pharmacologically active by metabolism, but we make it just active. So that's the thing. That's the thing about the biotransformation of medication. Please, let's pay attention. Let me just add something here on the biotransformation. We talked about phase 1. We talked about phase 1 and also talked about phase 2. Okay? We said phase 2 are usually conjugation methods. For example, adding an amino acid, adding glucouric acid. Remember those processes. These are what we call conjugation process. They are phase 2. However, with phase 1, we add some groups. For example, an amide group. Okay, so basically here we just add or subtract functional groups. So usually we have oxidation. These are processes now. Reduction and the hydrolysis. These are 3 major processes that are in the phase 1, and then these are some of the 2 processes that are in phase 2. That's basically it. And please make sure, let me emphasize on the point, we have different kind of medications. Let's talk about these different kind of medication that undergo this kind of metabolism. We have some medications that can undergo one only. We have some medications that can undergo phase 2 only. We have some medications that can undergo both 1 and 2. And we have some medications that can, okay, let's just end there, because what I want to add on is just repeating itself. So you should understand that there's a medication that can undergo 1 only, 2 only, or both of them at the same time. So please pay attention to that. It's very, very much important. So I think we've answered to say the answer is less lipid soluble. And the reason why B is wrong, because we've paid attention to this MCQ, it's saying more pharmacologically active. No, you can't make a drug to be more pharmacologically active through metabolism, but you can activate the drug. When you are activating the drug, we mean it was inactive. That is the key point there. So now let's go to question 12. Question 12 is saying, which of the following processes proceeds in the second phase of biotransformation? I've just answered this question in the previous explanation. Which of the following processes proceeds in the second phase of biotransformation? In the second phase of biotransformation, we have what we call I gave you those processes. Okay, so when we look at hydrolysis, oxidation, reduction, these are what? These are phase 1. Okay, they are the first phase. Then acetylation, amination, gluconeonation, and other processes. Should go look at. You should go search about them. These are phase 2, and we call them conjugation processes, because we just add this and this. We put an amino acid, we put glucouric acid, we put acetyl, just like that. So basically question 12 has been answered. Let's go to question 13. Question 13 is saying, the most rapid eliminated drugs are those with higher glomerular filtration rate and actively secreted but anti-passively reabsorbed. Okay, so the most rapid eliminated drugs are those with high glomerular filtration rate and actively secreted but anti-passively reabsorbed. It's simple here. Okay, you know the glomerular filtration rate. The glomerular filtration rate is the delivery of drug to the nephron. Okay, into the glomerulus. So if you have a lot of blood delivery to the kidney, that's why you should first base the understanding. Let's review the physiology. If you have a lot of blood delivery, okay, if you have a lot of blood delivery to the kidney, okay, even what is going to, to the glomerulus, even what is going to lead the tube, this is the tube, the proximal tube, what is going to be filtered from these blood vessels here is what we call glomerular filtration rate. So we mean to say things that increases the glomerular filtration rate is that when the afferent arteriole dilates, when it dilates, meaning a lot of blood is going to be delivered to the kidney. So if a lot of blood is being delivered to the kidney, you understand, we mean even filtration is going to be faster. Now that blood is carrying some drugs. If it gets to be filtered, you understand, if it gets to be filtered, it has gone, then there's what we need to have reabsorption. Okay, so this drug has been rapidly been filtered. Now it is here. Now it's the body to determine its importance. Is it still important? Every important thing is being absorbed back into the peritubular capillaries. So if this important thing is absorbed back to the vertebral capillaries, that's the only way it's going back to the to the bloodstream. Now imagine in a case where this drug cannot be passively absorbed, meaning it needs to be actively reabsorbed. Active transports, they are not as efficient as the passive transport, because passive, a lot of substance can move through passive transport, and active transport is dependent on energy. If there is less energy, even the process is going to delay. So this is the reason why we are saying these drugs, they are more likely to be excreted. Why? Because they are not depending on passive transport for them to go back into the bloodstream, but they are depending on active transport, and which might not be reliable. So they are more likely to be eliminated. Let's go back to the question and see what it's saying. The most rapidly eliminated drugs are those with a high glomerular filtration rate and actively secreted. Secretion will mean they are released from the body, but anti-passively reabsorbed. If they can't be passively absorbed, meaning a lot of it is going to put to waste. So the answer here is true, and we don't need to say a lot of things on the answer I've explained. So in case you don't understand, just go back, go negative ways, go back to my explanation on the tube, you understand, yeah? So question 14 is saying half-life doesn't depend on the half-life of a drug, doesn't depend on. When we say, first of all, you should understand what we mean by half-life. Because if you understand what we mean by half-life, it's going to be super simple for you to understand what it can depend on. So we are saying half-life is the time taken. Let me write it down. We are talking about time taken for half of the drug to be eliminated out of the body. And if we say half-life is the time taken for half of the medication or a drug to be eliminated out of the body, yeah, if we say that, we mean to say for each particular medication have its own half-life. Okay, for each and every medication have its own half-life. So we can conclude to say there are some drugs which have long half-life, and there are some drugs which have short half-life. There are some drugs which are having moderate half-life. You understand? For example, the half-life of azithromycin, an antibiotic, is long. Okay, it's about 73 hours. So you can actually, when you look at the dosage of azithromycin, you just need to get 2 tablets, and you're going to get one. It's OD. You're going to get it once in a day. For 3 days, you are treated of any notorious and microbial, any microbial or bacterial disease. You understand? So we mean to say half-life is a designated, it's part of the drug. So now let's look at what can affect half-life. What can affect the half-life of a particular drug? Okay, let's look at them. The biotransformation. Does the biotransformation of a drug affect its half-life? Biotransformation, does it affect the half-life? Yeah, to some extent it does. We are going to come back to this option. Time of drug absorption. Time of drug absorption. Yes, to some extent. Concentration of a drug in the plasma. Rate of drug elimination. So half-life doesn't depend on which one. The half-life does not depend on time of drug absorption, concentration of drug in the plasma, or rate of drug elimination. What doesn't affect the half-life? So now remember I said the half-life of a drug is designated and they have their own half-life to say this is drug, this is drug. Biotransformation, for example, hepatic metabolism. Hepatic metabolism affects the half-life of that particular drug. How about time of drug absorption? Time of drug absorption. Time of drug absorption does not necessarily affect the half-life of a drug because it just needs for it to be absorbed. So it does nothing to do whether it drains, whether it takes time. It cannot affect the half-life. Concentration of drug in the plasma, of course. How much is in the plasma matters on how much is going to be eliminated. Rate of drug elimination, yes. Okay. Wait, the rate of elimination of a drug, basically the rate of elimination of a drug is more likely to be the wrong answer here. The rate of drug elimination does not affect the half-life of a drug. Actually, this one does. So, the answer we're going to remain with is time of drug absorption. Time of drug absorption does not affect the half-life. This one stands out to be the best answer. Okay, in as much as other answers can be a little bit questionable and contribute little, but this one stands out to be the answer where the half-life doesn't depend. Time of drug absorption does not affect the half-life of a drug, because at this moment it's not like if at all something has 2 hours. If a drug has 2 hours of drug elimination before it, like if the half-life is 2 hours, immediately after it's absorbed, that's going to occupy it. Yes, so B, time of drug absorption, can be the correct answer. The next one, 15. The elimination rate constant is defined by the following parameter. A, rate of absorption. B, maximal concentration of a drug in the plasma. Highest single dose. Half-life. Okay. So now what is the elimination rate constant? We are looking at how much of this drug is removed out of the body. Yeah? So elimination rate constant does not depend on the rate absorption. Maximal concentration of a drug in the plasma, not basically, not necessarily. For a drug, how quickly a drug is going to be moved out of the body depends on has an effect on the half-life of that particular drug. So the elimination rate constant has its own formula, and the half-life of a medication is in the formula of eliminating rate constant. Okay, half-life is in the formula of eliminating rate constant. And how the half-life affects the elimination rate constant, because half-life is under the coefficient and some constant figure of elimination constant. What I mean is like this. If we have Kelvin elimination constant, then we have a coefficient of upon 96 then times coefficient, then divided by half-life. Okay, so how small or big they have, or how okay, let me use this word. How small or big half-life is matters. If below here we are going to have a big number, okay, we're just going to use approximation. If the number is bigger, then we are more likely to have what? We are more likely to have low Kelvin's constant elimination. So we are more likely to have low answer here. Because imagine there is 2 and then here there is 4. We are going to have more small answer here. Then the opposite is also true, where in case we have a smaller number here, for example 1, and then we maintain the same 2, meaning we are going to have an answer that is a little bit higher than this amount. Okay, so what does this say? This means to say if at all the half-life is long, the half-life of a drug is long, even the current constant is going to be what? To be low. Okay, if the half-life of that particular drug is small, then we are more likely to have a high. You understand? So that's basically what it means. So the correct answer there is half-life.